Low-grade serous ovarian cancer is a rare disease estimated to represent less than 10% of new ovarian cancer patients. It is differentiated from high-grade serous ovarian cancer with different histological presentation, molecular profile, and clinical outcomes.
It's diagnosed at a younger age, median of age 45, compared to high-grade serous carcinoma, where the median is 63. Consequently, fertility preservation is of greater concern compared to the overall ovarian cancer population. 90% of patients with low-grade serous carcinoma are Caucasian. We also know that it may arise de novo or following a diagnosis of a serous borderline tumor, again underscoring the potential precursor lesion of serous borderline tumor. It may originate in the ovary or peritoneum. And like high-grade serous carcinomas, about 80% of cases are diagnosed in the stage 3 category. However, in contradistinction, compared to high-grade serous carcinoma, low-grade serous carcinoma is less sensitive to chemotherapy. Low-grade serous carcinoma is characterized by a prolonged overall survival, with the median overall survival in the 135 to 150 month range, compared to high-grade serous carcinoma, where the median overall survival is in the 40 to 60 month range. And nevertheless, approximately up to 80% of patients with low-grade serous carcinoma may eventually relapse.
Low-grade serous ovarian cancer is molecularly distinct from high-grade serous ovarian cancer, with BRCA mutations and homologous recombination deficiency being rare in this disease. Instead, we see alterations that affect the MAP kinase pathway as being the most prevalent alterations that we find in our patients' tumor tissue, primarily KRAS, BRAF, or NF1 mutations.
The MAP kinase pathway, or the RAS, RAF, MEK, ERK pathway, plays a prominent role in the pathogenesis of low-grade serous carcinoma. This slide highlights the importance of residual disease, both in primary surgery and in secondary surgery. And as you can see, women who had microscopic or no gross residual disease at completion of both primary surgery and secondary surgery had a better progression-free survival than those women who had macroscopic residual disease. And the same trends hold for overall survival as well. We also have learned a lot about the molecular biology of low-grade serous carcinoma over the past 2 decades. We know that it is very similar to hormone receptor positive breast cancer. At least 90% of low-grade serous carcinomas are estrogen receptor positive. And we also know, like HR positive breast cancer, younger women may have a worse prognosis than older women.